welcome to the session games government plays. Earlier I remarked when the government is the monopolist and they are not getting the result they want in the game, they just simply change the rules. That led me to reach out to my good friend and mentor, Dr. Norman Imes, who's put an incredible talk together for you. I'll say now, there are more slides than we likely will get through. When he sent me the slide deck and I reviewed it, he said, eliminate whatever we need to for brevity's sake. And I said, no, we'll leave it because the attendees need all the information he's put together. So the government changes the rules when they don't like how things are going. My one example of that affected me, I was recruited to Oklahoma City in 1990 to join an anesthesia group, primarily to do cardiac anesthesia. I had connected with two cardiac anesthesiologists here in Oklahoma City, Dr. Paul Bickett and Dr. Vance Robideau, who kind of anesthesia legend names in this area, just great people, extremely talented. And they showed me their books. I mean, they showed me what they would make doing a cardiac anesthetic for Medicare, Blue Cross, or whoever. And so I had an idea of how much money I was going to make depending on how many cardiac anesthetics I perform. In 1990, many of y'all have heard me tell this before, I was paid $1,100 for the anesthesia for an open heart surgery by Medicare. In 1992, after resource-based relative value scale part 1, that was cut to $550. And in 1993, not satisfied that they had reduced fees enough, the last check I received for a cardiac anesthetic for an open heart surgery, it was 6 hours long. The surgeon was a guy named Paul Canale. It's a horrible redo, mitral valve, bypass. We came off on balloon pump. It was a nightmare. 6 hours, I was paid $287. So the government changed the rules. There was no heads up. It was just a complete bait and switch. And so the entire United States had, the cardiac anesthesiologists trying to figure out how we're going to make a living. And a lot of them did what I did. They just quit doing hearts. So that was a real lesson for me. The government doesn't like the way things are going when they're a monopolist. They just change the rules. And that's what they did. And thank God they did, because when I quit doing hearts, I concentrated on all kinds of other things. And Steve Lantier joined me, and then we opened the Surgery Center of Oklahoma, disgusted with the whole damn thing. So Dr. Imes is going to focus, I think, mostly on MIPS today, and talk about how the government has just changed the rules and changed the goalposts. And once again, if we don't get through all the slides, those are there, I think, in the Hoover app for you to review later. So let's give a warm welcome to Dr. Norman Imes.
Okay, thank you.
Yeah, appreciate it.
Well, this is kind of an interesting subject because it fits into a lot of what we see in medicine, what's happened to it over the last 30 years. So when you have a concerted effort by, first of all, the government, and then that drifts down into other state government and these other entities that are making rules for us, it becomes pretty obvious there's one intent, and that's to get rid of private practice. They want you all driven into hospital systems where you can manage, the physicians better. In fact, you don't have to let them manage them, because the government does not have a very good history over the years of managing doctors and managing doctor payment. In fact, they've been very bad at it, which I'll show you some examples of that. So the only conclusion you can come to after looking at all this is there's a strong effort to get rid of anybody who thinks independently, who works independently. First of all, I'm going to give you a disclaimer. I am a cynic. and I'm a skeptic, so you can call me a cynical skeptic. And I think that probably pretty well describes me. I am not an expert on these healthcare games, and frankly, after reading about them, I don't think anybody is. I think anybody who says they are, particularly a physician, maybe misunderstood the question. And then I've played these games for 50 years. I've been a medical director in hospitals. I've directed, different kinds of programs in tertiary hospitals, transplant programs, and so on. So there's always some kind of rule, some kind of game you're always having to play. So I've done this chronically for a long time. I won't talk about, the fact this is a monopoly, and it's a monopoly that starts with the government downward. So that's the impetus is the federal government, and then they've empowered all these other people who then inflict different kinds of economic punishment on us. Now, one of the things I've tried to teach a lot of my residents and interns over the years is never take the word of anyone. And you really don't want to do that when you're talking about the government. So in the case of government, they're really not here to help you, any more in healthcare than they are anywhere else. But it's important if there's a new rule coming out or a new program coming out, from the government or any other entity, you need to understand the rules. So you can try to avoid them as best you can, or maybe not participate at all if you're really lucky. Now, one of the things that is always good to keep in mind is time is money. And as doctors, we sell time. And we got 24 hours a day. We can't sell any more than 24 hours a day. I've done a little bit of oil and gas business in my life. That wasn't bad. You got mailbox money. Whether you showed up at the pumping unit or not, you still got a check. But that's not the way medicine works. Medicine, you're selling time. So it's very important to remember that. But also, whenever they waste our time, whenever they make us do something that was totally unnecessary and unproductive, then what do? Well, you've robbed me, you've robbed my patients, and you've hurt the whole system by doing that. The only thing to look at in this is that last sentence down here. In game theory, the objective of game theory is that everyone plays by the same rules. So you have basically a level playing field. In our case, when we're dealing with all these different entities, whether it be our hospitals locally or whether it be the government, the playing field is not at all going to be level. Here's the people who write it. So all the people who write these rules, write these rules for us, are people who really are not necessarily directly involved in it, or they wouldn't write those rules. So the people who know something about it, the guy down at the patient level, he is not writing these rules. It's somebody above, in the hospital or one of these other entities. And of course, I won't go through all those because there's so many of them. So we have this huge number of people who are writing rules that we have to follow. Now, the other thing that you learn about this kind of game is that the people who write the rules, they have favorites. They have people that they prefer to win. So the government, for example, will enable hospitals to do things to us, or they'll enable big pharma to do things to us and to our patients. So there's all these different rules being written, but they have an agenda as well. So, when those rules are written, they're always changing, and they're always changing to benefit somebody, but never the primary care doctor. The primary care doctor who's independent is never going to be, in any system, is never going to be favored. Now, there's several myths that are out there. One is that the physicians who are owned by hospitals get paid the same as I do. They don't. They get paid, if they're a so-called integrated practice, they get paid at a different rate. And there's some examples there of how they're paid. You can see they can be paid, in the case of primary care, 78% more. And when you get down to surgery, sometimes 224% more. So not only do these entities like the government pay more, but also commercial insurance pays more. So commercial insurance typically will pay 200 to 250% more than the basic Medicare price that I get. Now, I don't know how many of it's affected here, but in commercial world, the commercial insurances 4 years ago, we took 95% of them. But then they decided to quit paying because I don't charge enough. If you don't charge very much as a doctor, insurance companies don't like you. If you think of how insurance is set up, it is always set up so that you make money from the premium. Well, if you come to me, you're going to have to cut your premium. Well, that's the last thing an insurance company wants to do. So they cut what they pay to me into to private practice. So private practice around the country, a lot of times we've had to get away from even doing commercial insurance. They pay even less than Medicare. So I only take about 3 or 4 commercial insurance products, whereas 4 years ago I took 100. But that's because they don't pay, because they don't like me, because I don't charge enough. They want you to go across the street to Integris and pay 10 times as much. And so that way they get to keep their premium elevated. Insurance always works the same. Always think through. They never want to cut the premium. Nothing you can do to improve efficiencies and so on will ever make them cut their insurance premium. So here's an example of how much they're paid, and I guess you can see that pretty well. They get paid a lot of money. So if it's so-called integrated practice, which means that practice is basically owned by the hospital and in that hospital boundary, then they get to bill under Medicare A as opposed to Medicare B. Now they will tell you, and when you Google it, even if you go into AI that's for medicine, when you Google it, they say, oh, everybody's paid the same. But you can see here, that's clearly not the case. They get paid a lot more if they're an integrated practice. The other thing is that, I know all hospitals are broke and, they need more money and et cetera. That's, in fact, Beth Israel is closing the doors, which is, that's been around, 200 years, and Beth Israel's closing the doors this month. So hospitals are really not very good at business. So if you think of how much money they get, so their doctors are working really hard, they're seeing a lot of patients, a lot of times they're integrated, and so they're getting paid a lot more money. And so they're seeing 3 times as many patients as I am, getting paid more, and they're losing money. If you look at what I've got outlined up here, it's at $306,762. That is the amount of money that hospitals are losing every year for the doctors they own. So every doctor they own, they're losing an average of $306,000. That's not good business. So they're making a lot more money for each service that doctor provides. And at the end of the year, they're $300,000 in debt for every doctor. Well, if you're Mercy or you're Integris, you own a lot of doctors. I don't know how many, for example, where I worked at Integris, I would say they probably own at least 2,500 doctors. Well, do the math. So you're down $750 million when you start the year by owning doctors. That's not a good business model, not one I want to be in anyway. So they really have to scramble to try to get those doctors to produce enough just so they can break even on the doctors that they own. But it's not because they don't get enough money. There's a whole lot of money going into the system. It's just they're not very good at business. Now, it depends on the specialist, how much they lose. You can see surgical specialists lose more than do primary care doctors. So each one of them has to be subsidized at a different rate. But that's one of the reasons why they're so draconian when they're trying to set up contracts with our physicians, because they've got these metrics they've got to look at, and they've got to meet those metrics, in order to keep the doors open, because they can't manage their money very well. Now I want to give you this idea here, just because this is where we start. So what do we get paid as doctors by Medicare? Well, that really hasn't changed any, for the last 23 years. So we've had no inflation adjustments for the last 23 years. So just by looking at inflation, what we get paid by Medicare, that amount of money has gone down, real money has gone down 33%. So what we're doing today when we play these games, each one of those games, you're already down 33%. Those are going to subtract from your bottom line. So you've already lost 33 just from inflation. Now you're going to play the game. That's going to cost you money, and you're going to take even more money out of our pockets. Now you can see the Medicare Economic Index, MEI, it has gone up about 50%, whereas if you look at the actual cost, look at fee-for-service. Fee-for-service is double as far as what it costs us to perform that service over the last 23 years. But at the same time, like I say, we're getting less money. In fact, we've got cuts this year coming up, so we're going to make even less money. So the government's way of handling this was they invented a new system. I think they got tired of hearing doctors moan about what the payments were, so they created a brand new system of gaming us a little bit, and we'll explain the so-called merit-based incentive payment system. I won't go through this slide in detail, but it's just it might be worthwhile if you're interested to go through that. It gives you the history of Medicare payments. What have they done over the last, since 1985 when it started, how have we been paid? For a long time, they used the SGR, which is called the sustainable growth rate. And basically it said that the amount of money that Medicare pays out per year has to stay constant. So with that constant payment, they added services. You had sicker patients, you had older patients, so you had a lot more services. So then you were having to decrease the fee schedule every year. So by the time it got to 2015, we had accumulated a net loss we were going to be saddled with a 21.2% loss in payments under the fee schedule in 2015. So they'd done some patchwork over the years. So this is all accumulated. So each year that we did not keep up to that basically net zero, that they kept that number and they kept adding those percentages. So then you get down, we're going to lose 21.2% in 2015. So they turn around and they say, well, we can't do that. Doctor's not going to like that if you cut them by 21% in 1 year. So we're going to have a whole new system. We're going to shut them up. We'll create a whole new system. You still don't get paid anymore, but we're going to make you work for what you get. So they invented this merit-based incentive payment system. And what this is it's basically a system where the amount of money that Medicare pays stays the same. It never goes up. You're not going to get more money by participating. So it's what we call a zero-sum game. So in order to make this work, you got to say, well, you're a good doctor and we're going to pay you more, and you're a bad doctor, we're going to pay you less. So that was the intent of the whole program, is so we had winners and losers, but the total amount of money that was paid to the doctors stayed the same. It didn't make any difference whether you were all good doctors. In this system, you can't have all good doctors because they've got to have winners and losers. You got to have somebody that's going to get more money and somebody's going to get less. So it's got to be what's called a zero-sum game. So that's the game they set up. Now these are the rules. It took me 10 minutes just to download them, and I didn't read them all. But these are the rules of the game as they came out in 2015, 2016. So, I don't think any doctor in his right mind read those. There are some people who actually, of course, read them because they have consultative services. You hire somebody who read the rules, who understands the rules, and those people are supposed to tell us what we're supposed to do to run this program. Because I'll guarantee you, no doctor really knows how to do it. So you got to have a computer system that does what they want, and then you also have to have somebody explain to you will explain to you how to do it, and then you have to do it. So that costs money, but you're not paid for it. Now, what does it cost the doctor to play the game? Well, it costs a lot of money. And if you just look across the board, when you might look at the second red box down there, that's small primary care doctors. So you can see some of those people are paying, a fair amount of money, $50,000 per doctor per year. So that's a lot of money. You got 3 or 4 doctors, that's a huge amount of money that comes out of your practice. Again, they're not paying any more money. You still get that same Medicare payment, but now they're making you spend money in order to play this game. So there's no government reimbursement for playing the game. So what you've done is you've created a system where everybody loses. It doesn't matter if they're what the government calls a winner, you're still going to be a loser because it's costing you more to play the game than you could ever win. Crazy system. Now, depending on whether you're in a big practice multi-specialty clinic, a surgeon. All these things have different costs for playing this game, but basically it's about $13,000 to $14,000 loss per doctor who plays this game. Now, these are 2019 figures. So in 2019, you figure the inflation since then, that's been about 25%. So it's actually a lot more expensive now than it was when these figures were accumulated. Now, if you look at the midpoint there, the total payments, they stay the same. But what they do is they have you fill out these forms, and you have metrics that the government looks at, and they decide whether you're a good doctor or a bad doctor. If you meet their benchmark, then they'll decide how good of a doctor you are, and they'll pay you a little bonus. If you're not what they consider a good doctor, they will take money away from you. They will decrease your Medicare payment. So, and that's as you go forward, that start at 4%, and it's now up to 9%. So that's how much you could potentially win or lose. If you did really well, then you could get 9%. If you did really badly on their metrics, you could actually lose 9% of your fee schedule. Now, the problem is that most doctors are pretty good. So nobody's a big winner, nobody's a terrible loser. So it's basically like almost no change across the board. But again, the total amount of payment stays the same. It just costs you to play the game. So the problem is that when you set this system up, it makes a presumption that Medicare knows what quality is. Medicare can measure quality and also they can measure the outcome. And those, as you probably know, are some real stretches of the imagination. I don't think they can do any of those things. I don't think they would know quality if it hit them upside the head. But it really doesn't make any difference because that's not even what you're looking at. You're looking at whether you fill out the boxes right. So if you hire a good consultant and you fill out the boxes right, you get a little bit of a bonus. You get a little bit higher payment. Well, let's say you do $300,000 worth of business with Medicare. Well, if you do $300,000 worth of business with Medicare, it costs you, let's say in my case, it might cost me $25,000, $30,000 to play the game. Well, in that case, what can I win? If I were the grand prize winner, I could win 2.15%. Well, what's 2.15% times 300,000? About $6,000, $6,500. So I can win $6,500, but I'm going to lose $25,000 by playing. What a game! That's just bizarre, and it's mind-boggling. Of course, when you start looking at these rules, just the amount of time, the amount of money you've got to spend to get a consultant in, get this thing all set up and do this on a daily basis, it is astronomical. And I don't think that even those numbers capture the real amount of money that you have to spend. And remember, time is money. So if you're spending your time, you're losing money. So it hadn't been very good for us. The worst you can do in a net sum game of zero is be zero. Now, I'm surprised they admitted this. In this particular cartoon, that's actually that benchmark right there. I pulled that out of the MIPS playbook. And what it says is, we're not going to tell you what the benchmark is. We're not going to set that until later because they can't tell you up front, because then everybody would have what to shoot at. So they don't tell you what the benchmark is until the end of the years. And they get a chance to analyze the data because they got to choose the set point. They got to choose the set point at which to set that benchmark so you can have winners and losers. It's not whether you do a good job. It's whether you've got to create winners and losers, basically arbitrarily. Remember, you're not reimbursed for what it costs you to play the game, and you're always going to lose money. You can be the grand prize winner, and you're still going to lose money. There's no way you can win. So it's a classic, Lucian and Peanuts sort of game. MIPS is the football. You try to kick it, you try to do right, and it gets moved. They move the goalpost. Now, this is a sidebar Some people, they didn't do MIPS. They want to push you really in the hospital system. So they created a system in which they would give you 5% if you'd play the game at the hospital. So that's what this system is. That's got a whole different set of rules. So, and that's another several thousand pages of rules. And there's about 100 of these things, and each one of them having their own set of rules. So it gets really, really complex, and obviously it takes somebody who costs you a lot of money to hire as a consultant to come in and get this put together. Well, let's run some numbers on that, because if time is money, and this is, remember, 2019 sort of data, you've got 535,000 doctors who played the game, and they're losing, at that time, $13,000 a year. So that means about $7 billion went out of our pockets as doctors. Now, all players are losers, never no winners. Even if you happen to be one of those who got 2% increase, it still costs you a lot more to play the game. But there's some people who lose more than others do. That's about the only good thing you say about it. What we don't know is, you can see this is a huge program, just all kinds of nooks and crannies, and, thousands of pages of rules and regulations and how you do it. It's a whole industry. And so that costs a lot of money. Who knows what, government doesn't tell you what they spent to do it, but I'm sure it wasn't cheap. But the other thing they don't tell you is how many people got killed by it. If they're taking away my time, they're taking away my resources, people are suffering. Patients are going to suffer. Patients are going to die. They don't tell you that. They're not going to calculate that. But that's really the most important thing that's out there. Okay, now we've done it. Now is it going to work? Well, no. As you might imagine, it doesn't work, because it's a nonsense game. And so what they found when they analyzed this is there's no correlation between your MIPS score and your outcome by a non-biased observer. In other words, did you have better outcomes if you scored higher? Nope. Some guy who scored low frequently scored very well on patient outcomes. And some guy who scored high because he had a better consultant perhaps, he was a lousy doctor, and he didn't do so well. He didn't have good outcomes. So the whole game didn't work, but again, that's a typical government sort of program. No correlation between how well you scored on MIPS and how your patients did. Now, here's another little game. This is one that just came out recently. This one is, the training that we have to do for opioid administration. So in order to get my license from the DEA, I have to now do 8 hours of training. I've had a license for 50 years to prescribe opioids, but now I've got to do some special training. And so what was the problem? Well, the problem was we had a lot of public outcry because there was a lot of deaths from opioids. We had opioid deaths in 2023 of 117,000. 75% of those are due to illegal fentanyl. Then about 15,000 were due to legal drugs that were misused or accidentally overdosed on. So the number of doctors that actually prescribe illegal fentanyl, I couldn't find there were any, so I don't think there are any. But then the government's solution to this was not to control the opioid flow in the government. The Biden administration did not do basically anything for 4 years to try to slow down the opioid flow into the country. So the basic problem that was causing all these deaths, they didn't even address. And instead, they said, well, we make these doctors do 8 hours of training. And of course, didn't have anything to do with the problem. Certainly not the solution to the problem. So when you look at that, then if you, again, just time is money. What's 8 hours of time worth? Well, most doctors, if they're working, an average doctor is going to generate about $500 an hour. So you got $4,000 for every time that somebody does the training. Now you turn around and you look at that, and there's 1 million doctors who get a DEA license. So then you got another $4 billion. Again, we're not getting paid anymore. It's just another $4 billion out of our pocket. So now the other question is, did you save any lives? So I went on a medical AI exploration and a search engine, and they said, well, no evidence you saved any lives, but the doctors learned how to give Narcan, squirt it up the nose. And that was about it. So anyway, again, we don't have any evidence that there was any lives saved. There's no data that there's ever lives saved by having me or anybody else do this training, because we don't prescribe illegal opioids. And here's the most destructive game of all. I would say if I had to pick one thing in medicine that has been the most destructive of everything we've done, it's the electronic healthcare record. And it has just been bizarre how much time and effort that we put into it, but the people who designed them just don't seem to be able to make them useful. And there's always evolving. There's a lot of different systems out there and so on. But if you just look at, say, what a typical primary care doctor spends, he spends 36.2 minutes per visit. Well, if you work for a hospital, you typically have to see a patient every 15 minutes. Well, if you're seeing a patient every 15 minutes and you're spending 36.2 minutes on every patient to do the electronic healthcare record, that doesn't leave a whole lot of time for your patient. And so guess what? Medical care is an afterthought. This is a billing system. So the electronic healthcare record is a billing system for the hospital or whoever owns that doctor. And it really is not a healthcare system. So our patients, they notice it. I guarantee you, they notice it. Oh, I saw that doctor, and all they did was type on their computer the whole time. They didn't even look at me. How many times have you heard that? But anyway, if you look at that, it takes an awful lot of time to do these electronic healthcare records. And this is just one study. There's dozens of studies out there about how inefficient and terrible this system is for just pulling us away from the patient and the patient's bedside, taking us away from our diagnosis and treatment of our patients. Well, this is what the CMS said that they were going to have electronic health records for. It's going to make everything more accurate, more clear, more available, and all the things the government says. You're going to reduce duplication, the delays in treatment, all these things that they had good ideas about. Was any of that accomplished? Well, that's a whole other story, but probably not. And here's just one conclusion by one study. Patient safety and quality of care are seriously compromised or flawed by the design, the functionality, and the improper use of an electronic healthcare record. And you can find dozens of studies say the same thing. It's an ongoing problem for the last 25 years. So it just doesn't seem to get any better. I noticed today they said, well, Dr. Burnout looked like maybe down a little bit. So let's run some numbers on that. So if we're figuring that you've got, again, $500 an hour of doctor time, it's taken 5.9 hours per day times $500 an hour. Then you get $29.50 per day that your time and money that you spent for that electronic healthcare record. And then you run that times 240 days a year that you work. And then you run that time the number of doctors. And then all of a sudden you find out doctors have, by doing the electronic healthcare record, have lost $708 billion. So you add all these programs together, we clearly lost from our bottom line where we started, which was already down 33%. We're talking about $1 trillion or so that we've lost below that. Not good. And it's no wonder doctors can't make it in practice, because when they play these games, it just snows you under. You can't really do it. So EHRs rob the physicians, their employees, and their patients, and it's basically mostly not compensated by the healthcare systems. And what they don't do is they don't tell you how many lives are lost. And I think we all could agree there's probably tens of millions of lives lost over the last decade or so. And the other thing we're not going to do is we're not going to calculate it, because the government doesn't want to know that. They don't want to know how many people are dying. Now, we might be able to fix this. We've got AI coming down the road. We've got AI scribes and so on. I like those. I think they're going to have a future. It's going to take time to develop them, but that'll maybe at least decrease somewhat the amount of time we spend on these electronic healthcare records. But we got to shorten those. We got to make them where they're important, where we capture the data we want and not data we don't need. Medicare did a study, and 52% of the the electronic healthcare record under Medicare's study was either cloned or just not done at all, just made it up. What can we do about it? Well, hopefully, people in this room are going to do something about it. People who are hired by a hospital system are not likely to raise their voice because they'll fire them. But we can. I think there are some things we can do, but it will require us to get control of our organized medicine people. That's the easiest thing to do, in my opinion. So if we can get people in organized medicine to help us here, I think the people of the legislature and the patients behind them, we can do some things. I think we can have some impact because patients are tired of it. And I think that, probably the insurance company doesn't have a whole lot of friends, either among patients or at the State House. So, and there's actually a bill out there right now looking at trying to change the indemnity of the healthcare, these healthcare insurance companies, because what they're doing is they're basically making us commit malpractice. They say, oh, well, we don't want you to use this drug or to do this procedure. We want you to do this one. Well, that's not standard of care. Well, if it's not standard of care, that becomes malpractice. But we get forced into it for their economic gain. And so in order to get past that, we need to remove the indemnity of those insurance companies. Now, one of the things you get into in Oklahoma, and I don't know if that's what's holding this bill up, is whenever you apply something to healthcare, it probably is going to have to apply to all insurers. So property and casualty, things like that, they're going to fight it. I think everybody else in this, as far as healthcare is concerned, they'd love to have something happen. But at the end of the day, we've got to just get people together as an organization, as a profession, and say no. So if we have a strong organization and we decide that doing pre-authorizations is nonsense, we don't do them anymore. What are they going to do about it? If all the doctors in Oklahoma say, hey, we're not going to do this anymore, it costs us billions of dollars a year to do these, and we don't get compensated for it. Let's just not do them. You pay us, and we'll do them, but we're not going to do them otherwise. But that's the kind of thing it's going to take. It's going to take some real drastic action. Then I think things will happen. But as long as we say you roll over and as a profession and say, okay, we'll do whatever you want, then it's not going to change. They'll always take advantage of us. Okay. Thank you.